So, good morning, everyone. Can you hear me from me? Okay. So, good morning, everyone. Welcome to the session Social Inclusion and Harm Reduction towards an integral approach. This is a combined session organized by Correlation European Harm Reduction Network and Apdes. My name is Queiroz. I'm representing Apdes club, let's say, agency here. And Arenga Lara.
My name is Lazarus. I work for Harm Reduction International.
Yeah, from Harm Reduction International. Yes,
content.
and she will be co-sharing with me. Thank you very much. You are very welcome. Yeah, so that's a great. So this is a little. Okay. So the idea, of this session somehow is to reflect on the intersection between harm reduction services and harm reduction approach and strategies and the social determinants of health. What is going on, across Europe, and in particular in some regions that are the professionals working on harm reduction services, delivering services to the communities. They are feeling that something is lacking when they are trying to deliver these services to the communities. So, for example, when we are approaching these people to tackle and deal with hepatitis C, HIV, TB, and so on, normally we tend to focus on the health problem, let's say, and when we try and when we are, let's say, when we are asked to give them, to this population, to this community, a more integrated approach, something concerning, for example, housing, or concerning employment, or concerning education, normally we do not have the tools, we do not have the strategies, we do not have the skills and the resources to deal with it. So our main point here is trying to understand how can we combine, how can we intersect those strategies coming from the social dimension of community harm reduction based approach and the one coming from health. So for that, we have asked some colleagues of us to join us in this particular moment. So we're going to have a first round of theoretical approach by Jeff Lazarus, Inês Amaro, Marta Borges, and then Inês Amaro coming from Portugal. Jeff is coming from Barcelona, Spain, but actually by his name you can see that he's an Anglo-Saxonic person. But you are a global trotter citizen, let's say. Okay, so maybe you can start now with our colleagues, with this theoretic approach. Jeff? And I will do... So, I'm muted, and then I'm going to present Jeff, and then I will pass the mic to... No, I need to present you first. If I continue, I cannot present. Yes. I can? Okay. This is very complicated. Then I will give you the floor. Maybe I will do like this. Can you sit here already? I think it's better. You prefer to stay there?
Very relaxed.
Okay. No, I'm okay. Okay. So, Professor Jeff Lazarus, or Jeffrey Lazarus, is the head of the health system team at Portuguese Institute for Global Health, IC or ISGlobal, and an associate professor at the Faculty of Medicine, University of Barcelona. He's also the vice chairman of the board of the ISL, International Liver Foundation, and previously he was working for 11 years at WHO Europe and 3 years at the Global Fund. So he's very capable to talk about social determinants from WHO point of view. Thank you.
Thank you so much, Jose, and thank you, Yang, for the invitation to speak here. I was 11 years at the World Health Organization at a time when we were trying to put hepatitis C on the agenda, and there seemed to be no interest at WHO, no interest anywhere. And the Correlation Network was holding a meeting in Sofia in 2007 and invited me to speak on hepatitis C. And I found the picture here from 2007. So as you can see, nothing's changed. The agenda of the conference is a bit the same, although we have a lot more on hepatitis C, and I'll be in a session later today where we'll really be able to talk in detail because so much has changed in that field with the advent of DAAs. Like other speakers before me, I have to say how wonderful it is to be back and to see everyone. I mean, there's almost 400 people here, which is absolutely amazing. As I understood, only about 2 cancellations. So this is becoming one of the bigger face-to-face conferences in all of Europe. And as Jose said, what I'm going to do is take a bit more of a theoretical approach and talk about people-centered health systems. In February 2007, when I spoke at the Correlation meeting, we had no framework for understanding health systems. That same year, WHO launched their framework, which I'm going to present, but then I'm going to show how, working with the Correlation Network, FEANSA, ILGA, other groups, pan-European groups dealing with marginalized and vulnerable populations, we were able to make that framework more fit for purpose, something that we can all use to assess the services that we're providing or that are providing healthcare for people who inject drugs and other marginalized populations. So we know that many vulnerable communities most in need of healthcare in Europe are amongst the least likely to receive it. So we're all on the same page there. Why is that the case? So when Jose asked me to speak about social determinants of health, it's fine, I thought, well, what has changed since 2007? Because certainly the actual social determinants haven't changed at all. But what's changed is that the World Health Organization has really taken this onto their agenda. So you see here the conceptual framework from the WHO Commission of Social Determinants of Health. We don't need to go through all the details of the actual framework. Suffice it to say that what they report is that the conditions in which people are born, grow, live, work, and age, and the fundamental drivers of these conditions, that's what they mean by SDOH, social determinants of health. They include all of the non-medical factors that influence health outcomes. And structural determinants consist of social, economic, and political mechanisms that give rise to a socioeconomic position, and based on this socioeconomic position, the social determinants of health are shaped. I feel like I don't need to tell anyone here this. It took WHO a little while until 2010 to realize what everyone here knows about the social determinants of health and how these are shaping the individuals who are marginalized and vulnerable, and how we need to absolutely address them in order to make services more effective, more fit for purpose. This is a little bit of a redesign of what WHO launched in 2007, the very important, I think, framework on health systems, from leadership and governance to the workforce, to the medical products, information, financing, and service delivery. Those are what we call the 6 building blocks. WHO used to have them one above the other. Everyone would complain, why am I not first? Why is that second? So they made it into a circle. And 3 or 4 years later, with all of these, different building blocks, people said, well, what are you building this for? Where's the community? Where's the people? So they changed their framework into what was called a people-centered health systems approach, and simply plopped people right in the middle where you see that. As you move through the framework towards our goals, you'll see 4 interim goals, what I call the public health challenges. Those are access, coverage, quality, and safety. And I remember, presenting this in earlier years, and it's always hard to remember, but during the COVID-19 pandemic, thinking about testing, thinking about face masks, thinking about gel, thinking about vaccines, we know that access, coverage, quality, and safety is on not just our agenda, but everyone's agenda. I mean, my daughter, the vaccine's safe. How old do I have to be to get them? Everyone knows now about the WHO framework. They just don't realize it's the WHO framework. And the ultimate goal, what WHO sets out as the ultimate goal of any health system, is improved health. Now, when they had that discussion in 2005 and 2006 and finally agreed on it in 2007, they put in parentheses level and equity. So I draw your attention to equity. That's our focal point in the health systems framework, because this is where we can say, even if 80% or 90% have access, have gotten that treatment, have gotten that test, if any populations are below that threshold that's been agreed on, i.e. it's not equitable services, then it means those services are failing. So in this case, we're very lucky. We need to read the small print, but equity's there, and that's our hook. So integrated care, as as Jose said, is sort of the theme of this session, and I think really the theme of this conference and all the work we do, because we so often work in silos. There's many different definitions. So what WHO says, this is the comprehensive delivery of quality services across the life course, designed according to the multi-dimensional needs of the population and the individual, and delivered by a coordinated, multidisciplinary team of providers working across settings and levels of care. And wouldn't that be nice? This is a hard definition to remember, but it's a great definition because this is what we're striving towards. So some of you are achieving it, but reaching different levels, always being able to have multidisciplinary care is quite a challenge. And you see here on the figure some of the key individuals, the key stakeholders that need to be involved in an integrated approach. So integrating now the social determinants of health into health systems, that's the trick. This is the closing the gap that how WHO puts it. It means that within each country, to improve average health and reduce health inequities, we need actions on the social determinants of health as well. At the international level, we need to address the causes of inequities between countries. Some of the recommendations of the final report of WHO's Commission on Social Determinants of Health was to improve daily living conditions, to tackle inequitable distribution of power, money, and resources, and to measure and understand social determinants of health and assess the impact of action. Many of you are working on daily living conditions. I don't really know who's going to be able to tackle inequitable distribution of power and money. I'm working along with other researchers certainly on measuring and understanding the social determinants of health. So we have a lot of work to do, and we need many different stakeholders involved in that. So the Nobody Left Outside coalition that I mentioned earlier that brings together many of you pan-European organizations has been looking at some of the healthcare access challenges among marginalized populations. Some of those populations are listed here, and they outline the main health risks from infectious diseases to communicable diseases that you see on the left here. The barriers, and these are just some of the barriers, education, organizational, administrative, legal, stigma, discrimination, why there's low service uptake and what we can do about it, how to promote health better, how to improve harm reduction services, diagnosis, treatment, supportive care, and finally how that low service uptake leads to poor outcomes, which ultimately leads to morbidity and mortality, to death. So it leads to excess care costs, it leads to public health threats, and it risks achieving the Sustainable Development Goals. And of course, during the pandemic, we've had a huge setback. So we know that marginalized, underserved groups are not necessarily hard to reach. We just have to want to reach them. They're hard to reach for some people, but I think it's generally a lack of will and effort than it is that the populations are so terribly hard to find. So we talk about this people-centered approach, the integrated approach. Integration from a theoretical standpoint doesn't always mean co-location of services. It doesn't mean that everything is in one place. It also means that they're well linked. Sometimes it doesn't make sense, and both financially and physically, to have everything in one place, but we need the better linkages or we lose people to follow up in that process. Obviously, stigma and discrimination are constantly raised as issues. I work a lot in the HIV field, and we had a unique opportunity to meet with the Commissioner for Health for Europe 2 days ago, and we were lamenting the fact that in 2021 there's still so much discrimination, even legal discrimination on the books in some of the EU member states about the employment people living with HIV can and cannot have after all the efforts we've made to change that. So the NLO service design checklist, and I'll finish up. What we did was we took those 6 building blocks and we made a long list of questions. Let me zoom in on it. And we said, for example, at the design stage, is the community or was the community involved in designing that service? And in the design considerations, we asked questions like, were the health but also the social care needs of the community addressed in that service? So this gets to some of the integration you mentioned, that health and social care should not always be separate. And this service design checklist, which is freely available online, raises a number of those questions so we can be systematically assessing services. And it's very interesting. We carried this out in Barcelona, asking those at the center and then asking the community, and there's a huge disconnect. Whereas the people at the service think the community was involved in being cared for. The community said, we don't know what's going on. We didn't agree on the opening hours. It's not easy to find, and we would do things very differently. So this is a tool we developed that can help do that. And so let me just conclude with that call that health systems need to be much more equitable, just, and effective. And I included here just two of many, many articles during the COVID-19 pandemic, because there it really reminded us who are the marginalized and vulnerable populations. And here, this first article on the left, Susanna Jakob, who set up the ECDC and then led WHO, is using that language and focusing here on the case of migrants. So in conclusion, new service designs are needed to improve health and social care access for marginalized, underserved communities. This checklist I presented is a tool that can help providers, policymakers, community representatives to be more people-centered and to have services that are based on needs assessment, that are integrated, that are adapted to enable access, where the workforce is better trained, better educated, we have the financing leadership and governance considerations we need, and that the community is involved in this process from the very beginning. And there are examples where that's the case, but in the majority of cases, it's not the case. Thank you. Thank you.
Thank you.
Thank you so much, Jeff, for the strong theoretical foundations that will shape our discussion for today. And I would like to introduce the second speaker, which many of you knows, I'm sure. Marta Borges. She is currently the director of the Social Emergency Department in the Portuguese Social Security Institute. And before that, she was the regional coordinator for the Lisbon harm reduction in the DCAT, Division of Interventions and Addictive Behaviors and Dependencies of the Regional Health Administration of Lisbon and Tagus Valley. Marta, the place is yours.
Does it work on the online presentation?
Okay.
So, hello. Unfortunately, my English is not so good as Jeff Lazarus, so you are going to make a big effort. Thank you very much for listening to us and to be part of this social determinants of health approach that I feel so needed when I think about harm reduction. So I brought here to you a bit of my thoughts that I want to share. And I start with a Portuguese movie where a guy lends some money to a mental ill man that lives on the streets, and he says, I'm going to spend it badly. And that happens very often when we are advocating for our clients, when we are doing harm reduction. And we have to explain, because many services says to us, he's not stopping drugs, he's not moving towards a solution, he's spending money badly. So we have not only to advocate for the human that we have in front of us, but we have to explain that this is part of life. When I'm on a diet, I said to my nutrition, well, I'm going to eat croissants when I'm in Prague. So every and each one of us do bad things, and that's not a bad thing, okay? But we still have to say it out loud every time we are advocating for one of our clients. When I stopped working in harm reduction, and now that I'm coordinating the Portuguese National Helpline, that is a helpline that works 24 hours a day, I always bring my people with me. So 20 years of harm reduction, I brought into the social helpline my perspective on drugs, on people that use drugs, on sex workers, on LGBT community. And what I felt is we are not responding to people. We are not responding. We are leaving so many people behind. because of so many things and because we separate. And my matryoshka effect, that I will call Luana because of one of the women that I met in Metzineres. We look like this, but we need to look it up like this, because we are so many things besides disease. Okay, so I felt I need to share with you this matryoshka effect that I feel the service don't address to it. And we know, as Jeff told us, that if I stay longer and longer in the streets, I will become more ill. Because being on the margins of society brings more illness to it. And in the end, it will be economically more expensive to all the governments, because we didn't address our people and our communities in the beginning. So, because they don't fit in every services that we try to implement in our communities. So, what we are doing is that we are creating fragments, inequalities, and we are not improving the access, and we are perpetuating the maintenance of people in the system, because we are not seeing our Luanas as a person, a human being. We are seeing them as like parts of one person, because and I brought some ideas of what I want to say to you. Every time I talk with my teams in the social helpline, if we fit in one of these, or in more than one of these layers, we don't fit anywhere. Because if I want to put someone in a shelter, if he or she has a dog, she doesn't fit, or he doesn't fit there. If she has child and she's homeless, she doesn't fit. If I'm a drug user, active drug user, and I'm aged, I don't fit in a place where my grandmother lives, because I still use drugs and I don't fit there. So even though we are creating many responses there, we never address people's need. Okay. So the only solution, as Jeff was saying, also is to create services that are more plastic and that can adapt to all the layers of Luana's living. So I think the first thing is creating non-judgmental services and training new professionals towards that. And I do think that harm reduction does that very well. I think we need multidisciplinary teams, and the approach when we think about drugs, when we think about HIV, we have an history of multidisciplinary looking towards people. So we need to bring that look into creating new social services, new social approaches. But we also need to convoke pharmacological interventions on that, because we know people are more ill and people are more mentally ill because of all the social determinants of health that we cannot address in the time of living of that person. And we need active outreach. For example, what happens to me that in my service is that we work 24 hours a day, and the only service that works 24 hours a day besides us is the hospital. So if we don't have anywhere to send the person in need, we have to say, wait in the hospital, and we can address to you later. So it's very difficult to manage the needs, the emergency of the person in need, because we don't have the responses we need 24 hours a day, because people live 24 hours a day. And if you think about shelters, you think that if I'm a sex worker and I work in the night and I'm homeless, I don't have a shelter during the day where I can rest. Or if I'm an aged user and I have cancer and I still use drugs, I need to rest. And I don't think we as a community are creating places of staying, places of being, where I just can stay there, okay? So I think that's what we have to think about when we are talking about these social determinants of health. That is addressing all the layers of one person. And in HIV, all of us are used to hear linkage to care. And we have to amplify linkage to care not only for HIV, but for social services. Okay, because I think this professional that does the linkage is a useful tool to link healthcare to social care. And also, treating is not necessarily caring. That is another thing. So we should humanize the care when we are treating socially and medically a person. So my solution that I bring here to you and to discuss with you is harm reduction a possibility to be this linkage worker that advocates for new responses, because we are non-judgmental as an approach, as a model. So I think maybe this is the starting point of something that is an integrated response that we all advocate for. Okay, I'm just finished. And we cannot talk today about anything without talking about COVID. COVID changed everything, and especially it promotes the look that we need to address people, because people are social in need of care and attention, and we are all in need of care and attention. We are all in here. We need to hug our colleagues that we don't see for many times. So imagine people that are have not the possibility of belonging to a network. So COVID brought to us this need and this look to be more focused in integrated response. And we need to be aware of the lack of responding to funding harm reduction, because all the looks are towards the pandemic, all the looks of funding are towards COVID, and we have to be, maybe we are endangered as a response, because funding for harm reduction may be endangered, and I think this has to be our mantra, so we can address to it, and because we have a good service in many cities of Europe and in the world, we are not sufficient, and we cannot drop services. We have to improve for new services. So I think harm reduction lenses that we bring towards our community maybe is the necessary approach that we need for an action in a human rights agenda. Thank you so much.
Thank you so much, Marta, for your presentation. And I would like to invite our third speaker, Inês Amaro. Inês is from Social Security Institute in Portugal. She will also present back the result from yesterday's workshop. Inês.
Thank you. Yes, I should have it here.
Okay, sorry. Is it here?
No.
Here? Okay.
Is it okay?
Yeah. You can use this as well for easier.
Okay.
Yeah.
I have to take the mask off. Okay, good morning, everyone, once again. First of all, I would like to thank you, the ones of you that participated yesterday in the workshop, and the ones of you who took some time to come here to hear what are our thoughts on harm reduction and social determinants of health. And in fact, our goal, actually I was challenged by Marta to come here and to share with you our concerns coming from a social perspective, more than from a health perspective, on how these harm reduction intervention or harm reduction approach can be a powerful linkage between healthcare and social care towards an integral approach. So I do not have much to say about the initial framework, but just a few ideas that was on our minds when preparing this moment. And the thing that we know about social determinants of health, that is the main idea that the health condition of a person is never only about their state of body and mind, and has pretty much to do with he or her social condition, social position in the her position in the social structure, and many of these factors the person itself can control, but many of them the person herself or himself is not able to control. And what can we do about this? First of all, we think it is important to address and to recognize the existence of this idea of social determinants of health, which is much more easy to agree upon when we are speaking than when we are acting. And I think that all of us experienced in our daily working lives that many times we are just stopped and faced with some visions who interrupt people in their own pre-social conditions that refrain the possibilities for them to get out of that situation. So we think that harm reduction can be seen as a human rights-based approach, and this means that when we are working coming from a harm reduction approach, we are actually dealing with the social circumstances of people, and we are putting the look into people first, seeing the person first, and then addressing their social and healthcare needs. And this is really important once this means that we are addressing people as a human being in its own dignity, and not seeing only the problem or only the bad situation that we are trying to solve. And in this sense, we think that it seems pretty obvious actually that harm reduction can work as a powerful link between health and social care. And this applies for each of these kind of dimensions that people need to be addressed, and that are conditioning and having an effect on their health condition. So how come that we find ourselves and the civil society organization with which we work in partnership struggling to tackle the social expressions of health problems and the health effects caused by the social factors they are dealing with? This is so obvious, but also so difficult to put in practice, and so difficult to recognize and address when we are working with people. And at this point, a third key idea that we have is that there is a need of a kind of a policy action, and we think that the policy action is a dimension of the professional practice which is attainable to each professional from the grassroots movements to policy decision-making level. And at this regard, the idea is that there is a whole field of advocacy that is needed to be developed by each professional in order to put these kind of concerns in the agenda, and these kind of concerns being approached when working with people. So we might understand policy action as activities undertaken by social workers or other, I'm taking this from social work, but it can be applied to other social interventors as an integral part of their professional activities on diverse fields and types of practice that focus on formulation and implementation of new policies, as well as on existing policies as suggested changes in them. These activities seek to further policies on the organization, local, national, and international levels that are in accordance with our working values. So how can we, from an harm reduction perspective, advocate for an intervention aware of the social determinants of health with its implication and effects, and pursuing an integral approach towards individuals and communities? Is this issue is this an issue for harm reductionists? And it was with these questions that we came here yesterday and organized the workshop and invited you for a discussion around it. And apparently, yes, this is an issue, this is a concern, and this is something that all of us in the field feel like important to address. Yesterday we have made some quick survey, and we see that much of our colleagues here spend time working on the social determinants of health, but also think that national public policies should be addressing these social determinants, and that can be more effective on doing that. Also, the majority of people present yesterday thought as important to address social determinants of health in their practice, but they are not quite satisfied, and they recognize it is very important to think about advocating strategies at this regard. So, trying to wrap up and sum up some of the ideas that came out yesterday on the group discussion at the workshop, we have identified some state-of-the-art and key ideas about what are we thinking about this issue, and thoughts about intersectionality, which hinders the access of people to a proper social and health care, and the way in which the combined characteristics of people, personal as well as social as well as health characteristics, might function as underlining their privilege or their disadvantage towards the others and towards the social system as a whole. So also the idea that there is policies, there is responses, but there is a problem in guaranteeing that people have access to those policies or to those responses that have been set up to respond to problems. And this has something to do with the prevalence of stigma and ignorance, and especially when it comes to some phenomena that fills the whole space like they are total phenomena, like active drug use and mental health. And what we saw yesterday that is somehow transversal in different countries is that when a person has a mental health problem, services tend to look at the person as if she or he is only a mental health person and not a woman or a man or an old guy or anything else. And the same happens with active drug use. You can have a broken arm, like it was said yesterday, but the doctor only sees that you are using drugs. And so it doesn't take care of the broken harm because you have to go into treatment for stopping using drugs. And this is a kind of an ignorance about social phenomena that function as, in fact, as a way of oppressing people. I'm running out of time? Yeah.
2 more minutes.
So still we have a fragmentation paradigm which entraps people into vicious circles, infinite loops of being pushed aside inclusion and protective pathways. What can be the role of harm reduction approach? It's a role of filling the gaps, of always having something to offer and something to give to people in addressing their needs. And linked to this, it is a role of connecting dots. And this means that the harm reduction approach can be the key or one of the keys to make a link into different services which are many times functioning in silos, not communicating to each other. And this is a kind of approach that can have this role. And also a very important role concerning the peer work and the way in that peers can be also a strong link to connect people with the services and with their own rights. Third dimension of analysis is about skills and education for working with social determinants of health, and in particular in harm reduction approaches. And yesterday this was discussed, and it was recognized the need of professionals to be aware of this complex dimension, to be aware how social determinants, how health and social characteristics of people and societies are intertwined and interlinked, and how they influence each other. To conclude with some recommendations and steps to take. We can conclude that harm reduction can be seen as a landmark for addressing social determinants of health and linking social and healthcare services towards an integral approach. Harm reduction is about recognition, respect and acceptance, and this people-centeredness approach is a gift for society as a whole. There is a need to develop advocacy skills among professionals and peers, and to combine the advocacy actors such as communities, service providers, activists, researchers and politicians. And all of these stakeholders should be involved in the process. The importance of knowing how to deal with metrics and to put and how to use the metrics to put pressure on political decision making. And it is also important for harm reduction approach to be able and to develop skills to dialogue in these economicist framework, and also demonstrate how the costs involved in the casualties, in the emergency interventions, in the crime control that comes from what doesn't work with when harm reduction is not taking place and when social determinants of health are not being addressed. And these also have a cost, and it is important that we can use these arguments to reinforce the approach of harm reduction in addressing the social determinants of health. It is also important to refuse this. Having said this, it is also important to refuse the simplistic metrics and also to make a public discussion around how people's lives change and how people's rights can be advocated by the services who are working with people. And linked with this, it is important to question the idea of success in an intervention process and to reach a common understanding about the purpose of harm reduction and how this harm reduction can address the social determinants of health. This was an exercise, a first, for us at least. We are coming from the social security system, so we are coming from the social dimension, and it is for us a first exercise to explore this potential of linking, and we think that the work is pretty much to be done and to be developed, and we count on networks like this to go further and to continue this kind of debate and its implications to an intervention model. Thank you very much.
Thank you so much. Thank you so much, Inês. Moving forward, we will have a set of 5 speakers who will respond to the previous presentations, but also share their experience in addressing 5 topics in relation to social determinants of health, which is women, housing, harm reduction, street support project, as well as inclusions. I would like to invite Aura Roig for now as the first speakers. Aura is the founding director of Metzineres, which is the first harm reduction program specifically for women and non-binary gender people in Spain.
Thank you so much. Okay, thank you so much for inviting me. We are really happy to see all these faces and be able to hug everybody, and we know that this is not correct, but we love it. Then we really want to say thanks to all the organizers that made this possible. For us, it's really important to be here, also because it's important to be able to share with everybody the knowledge and the experience. We know that women and gender non-binary people doesn't enter or don't arrive to the services. They survive multiple situations of vulnerabilities and violences, but they don't go to drug services because they only represent the 15% of the total. Then sometimes they are not safe places for them. Either when they go to services for male chauvinist violence, they find that because they are using drugs, they are expelled, or they cannot access directly, or they are expelled. Then they are facing a lot of barriers, lack of options, that finally ends in a systematic vulnerability of their rights based on prejudice, stigma, and social injustice. Then it's because that we decided to open Metzineres, that is the first co-op, only run by and for women and gender non-conforming people. These are our values, as you can see, radical alterness, everybody is welcome, collective resilience, because we talk a lot about resilience, but it's nothing that we can do by ourselves, we need to do it with our friends, with our community. Courage, because we need to be disobedient. No? Sometimes harm reduction became like a strategies, isolated strategies that they don't want to change the structural causes of inequality, but we need to be brave and talk about anti-prohibitionism, because we know that the problems are not the drugs, are the politics. Then we need to change that. Also evidence-based transdisciplinarity, like we need to put on the table new metrics that are really significant and meaningful for the people that are part of our community, and not just for the social control that sometimes seems that is. And transformative passion, we need to put a lot of energies on that, not sleep for a long time, and activism and mutual support, because it's not easy to be there. In Metzineres, we decided that, of course, we wanted to make sure that women who use drugs when I am talking about women, I am talking all the time about gender non-binary people also. I don't want to repeat myself, but I want to be clear with that. We wanted to be sure that they will be able to come to our service, that they won't fight a barrier. But as soon as we opened the door, we saw that the problems are not the drugs. The problem is all the rest of the situation that they are surviving, like mental health diagnosis, imprisonment, roofless, homeless, because we are talking about people who live in the streets, but when we see the situation that women are having in their houses before to go to the streets are terrible, then we need to take care that this is not also to have a home. To have a home is to be safe at home, and this is not the situation for most of the women. Racialized women, and all of them are surviving multiple situations of violence. When we began, we were thinking about having around 50 women. In 3 years, we have around 300. Then we know that was really important. That it's not that they are not there, it's because we don't have services that can, where they feel comfortable and safe again. Also, we wanted to make sure that we are not criminalizing all the drug use, because they use drugs to cope with a lot of other things. Then we need to take care what is problematic for them and what is not, and not think that because they have problem with one drug, they're gonna have problem with all the drugs. We have the right to use drugs if it's gonna be useful for all wellness. Then we wanted to show, for example, how methadone can be really important for the people, but at the same time, if we have to go to a doctor every day and we cannot have a word of what are the dose that we have, what is the schedule that works for us, can be also problematic. Then we need to take care of how we are giving this. And also we wanted to show the cannabis, for example, that most of our users of the women that are coming to Metzineres use cannabis to reduce the more risky behavior with other substances. No? Then when we talk about drugs, also make sure that we know. And when we are talking about violence, it's not just from their partners, that of course they are also, but how women are overrepresented in violence during the childhood, for example, and also how violence looks like when it comes from the institutional and the structure. No? We were talking a lot about that this morning, about how social systems, healthcare systems are also violence, also the violence that comes from criminalization, and also from people that they don't know just living in the streets. This picture is from a cabaret that we made this year. Then you know that we have a lot of fun. Then we are developing approaches coming from intersectional feminism, also harm reduction and human rights, where women are at the center, where they have all the power to define what autonomy looks like, what wellness looks like, including how they want to improve physical and emotional and psychological well-being of them. We wanted to reduce the barriers that women are facing all the time, doing a lot of different activities, but also supporting them to navigate to the complex social and care systems. Women have been part of the design, the implementation, the monitoring, and the evaluation of Metzineres since the beginning, in the same conditions that the rest of the staff members. We don't like to talk a lot about peers. We like better to talk about community technicians, because they are the experts of the community, and we want to make sure that we really make visible their expertise. And all of us are peers. No? We all use drugs then. And how they have to be leading the change in the public policies also, and make sure that we can support them to be present in all the definition of the public policies, and also we love to go to demonstrations or go to the streets. Then we like especially to go to the feminist movements, because sometimes inside the feminist movements they forget the women that are surviving the most vulnerable situations. Then we love to go there. But also to the general social movement that sometimes they don't realize how important, or they become a little bit prohibitionist. Then we love to go there. And also we have been developing a lot of new metrics with new indicators that we, together with other cooperatives that also are feminist and open source, in the way that we can share the information and the new indicators with other organizations. And I think that this is all. I have a lot to say there. One of the things is that for us has been really important to have fun, to not re-traumatizing women also. They are all the time are welcome. We don't have, they cannot be expelled from our place. Then if you want to know more details about how it's working in the daily life, we have another session later about girls' powers. We want to do the second part of the presentation. And also we want to invite you because our friends from Energy Control at lunch, they're going to have a showroom to show how drug checking works with new technologies. Then you are totally welcome, and look for us for any questions.
Can you say which room?
We don't know the room yet. Then look for them. Then we will announce them. Then, yeah. Yes.
Thank you so much. Thank you so much, Aura. And because we're short in time, I'm just gonna call the next speaker, Kerry Brennan. She is the Director of Services for Cork and Southeast Simon Community, which is an NGO that provides a range of accommodation and support services to people experiencing homelessness. You also have a presentation, right?
Yeah, the presentation
Yes.
somewhere.
This one?
Yes. Great. Thank you.
You have 7 minutes.
Yeah, I'll try to be very quick. I'll skip through a lot of the slides because I think a lot has been covered, and what I really want to have time for is I have a couple of short videos where some of our service participants share in their own words what home means to them and the things that they find meaningful in their lives. So just quickly, I think we all are familiar with the culture of harm reduction and the things that work to develop a culture of harm reduction in homeless services. I think it boils down to recognizing those things that don't have to be earned through sobriety or treatment compliance. And that's everything from access to respect to recognizing the person beyond their problems. And I suppose what the defining feature of Housing First is that it recognizes the right to have a home as among those things that don't have to be earned by participation in a program or by sobriety. Harm reduction practices I won't spend time on because I think we're probably familiar with them, but it goes everything from nutrition and hygiene needs to methadone induction programs to safe disposal of sharps to needle exchange. The services I'm here to talk about are the Housing First services in Cork and Waterford. They're delivered by my organisation, Cork and South East Simon, in partnership with another NGO called Focus Ireland, and also in partnership with the Irish National Health Service and the local authorities in the cities and counties where we deliver the service. It's part of a national implementation of Housing First across Ireland. And I'm more than happy to share the slides with people if you want the detail. I'm just conscious of time. I think people will be familiar with what Housing First is, but in a nutshell, it basically recognizes housing, first of all, as a human right, and again, something that doesn't have to be earned, but also as the first step, the stable base that enables recovery, whatever that means for each individual person. So the idea is that when somebody is sleeping rough, has complex needs, long-term homeless, that providing housing at the first opportunity without any preconditions for sobriety, without conditions around engagement treatment programs or medication or anything else, enables the opportunity for people then to contemplate and consider what recovery means to them and to take those steps with the support of a visiting team. And in our services, that visiting team looks like a multidisciplinary team where we have both social care workers doing home visits as well as clinicians, GPs, community health nurse, occupational therapist, psychologist, all involved. Just a quick note on the difference in applying harm reduction measures in a congregate setting, like an emergency shelter or group housing, versus in Housing First. I just think it's worth noting that however well-intentioned a service is in a shelter or a place where you're serving the needs of many vulnerable people in one place, however low you want the threshold to be, however inclusive you want to be, you always have to be mindful of how one person's issues may impact others. So if somebody is in active use and if that involves unsafe needle management or disruptive behaviours, intimidation, aggression, it is sometimes necessary with the best will in the world to exclude people from services to protect other people. Whereas in Housing First, the person has their own home, the services wrap around them, they come to them. You can manage risk, you can intensify support if needed, you can pull back if needed, but the person's access to home and warmth and somewhere to be isn't compromised in the way that it would be if they have to be excluded from a congregate setting. There are numerous other differences as well, but I don't think we have time. So just very obvious point, but I think sometimes the obvious points are the ones that get overlooked. Just looking at all the many ways, or some of the many ways in which the provision of housing in and of itself is the single most impactful harm reduction measure that can be taken in relation to a person experiencing homelessness. And I just listed out kind of off the top of my head a number of ways in which a person's, the risk and the harm that they experience is immediately reduced or even eliminated in a number of different areas just by the provision of housing. So I just have a video where some of our service participants talk in their own words about what having a home has meant for their lives. That's going to work. Oh, yeah. Is the sound? No. Good thing it's subtitled.
Anyone can help
with the toilet and sinks. Don't in there. Don't mind. The battery, it's got everything I need. Monday night, yeah. Alcohol. No, don't young girl.
Settings for it? No.
I can buy a drink off the shop and all of it. Come on.
Do you have any link?
My shop and all that.
Do you have any link to the
Oh, yeah, but we probably don't have time, do we?
That's one of the key workers. I don't mind, it's all right.
No?
Yes. Reason.
Yeah, I don't know. Sorry about that.
Myself, I want to see how to do.
Can you read the subtitles? Is it big enough?
In my eyes, I'm up, you know. But I've got everything in my own way. Everything's here. When I want to go to sleep, I'll get locked my door, make sure that's locked. Nobody's bothering me. So,
I was homeless myself for 10, 15 years, I'd say, on and off in a sort of a circle that was keep repeating itself. There was always mayhem and chaos always in my life, and just nearly coming up to a year ago I moved in. Peace of mind is priceless, and having a house is definitely peace of mind. Things are going forward since I moved into the house, like, and building a new type of circle of friends. It's actually nice to be accepted into a sort of a community and have good conversation, have a laugh and a joke with a lot of my neighbours. My mum's calling up, having a cup of tea, and Key Walker, my sister, my brother, different people that can call now into my house. So that's my foundation, and my mum and different things are building blocks. Like, it just has a knock-on effect to everyone around me, that everyone kind of wants to be around you a little bit more. As before, I wouldn't know where I'm probably going to wake up or where I'm going to go, what I have to do, and everything was on a whim, you know. My life is on a whim, you know.
I came along the streets, I slept in car parks, I slept in different areas. I just felt that there was no worth there. There was no self-worth in me no more. There was nothing there. I felt like a shell. All I saw was the bed. The hope they gave me like that, I had a choice. That I could go out drinking if I wanted, still the door be open to me. Or I could go out not drink and still the door be open to me. They didn't judge me. They didn't do that. But that was a great feeling. I got an opportunity to go forward and I got hope in my life. That's valuable to me, like. You know, very valuable to me, like.
So I know we're running out of time there. Just the last point I wanted to make was just around the importance of strengths-based approach to supporting people. When people experience homelessness, and particularly long-term homelessness or sleeping rough, in order to access services, they have to tell their story again and again and again. And often the questions that they're asked focus, necessarily on the problems they have and the issues that they need support around. But it's pretty rare that people have an opportunity to be asked about or to share the things in their life that are positive, or the things that give them that they're good at, or the things that they like about themselves. And so these are just some examples of some of the questions that we would ask people alongside the questions about problems and difficulties. There is another short video just where people are talking about the things that give meaning to their lives. I know we might have to cut it off. If
I sit in my doorstep, listen to music. I'm a very good drawer. I'm a drink and a smoke, but nobody else in it. Even sometimes going over that bridge and walking out the way, nice and quiet, and nobody come past bullied.
What I value most in life is nature, definitely, and the miracle of life. It soothes me. I'm definitely being talked to by an older energy anyway, I do communicate in my heart. I love drawing trees. Arts means to me self-expression. It shows what state my mind is in, depending on how it turns out. It's like a reflection on paper. Things I love, things I'm interested in. I love the Aboriginal art, with all the spots and spirals. And I love ancient Irish drawings. It's a great medium between different cultures, you can share them.
We used to go out there and sit down and enjoy the sun, and then I started recognising the plants that was dying and that wasn't attended to for a while, and then I started kind of weeding them, and each evening then at 6 o'clock I used to take out the pump and I used to give them a sup of water, and I used to talk to them kind of be saying, "Oh, God, love, you must be gasping And then when I saw them blooming, I got more interested in it. That I got a gift of life, and I gave the plants a gift of life. I transferred what I received, even though it wasn't to a human being, it was to a plant. Do you know what I'm saying?
I do gardening every Tuesday and every Thursday. The reason I like doing cooking because my dad was a chef in the army, and when I was only 13 I learned from my dad. I suppose to get it right, that's my favourite part, and to just dish out the food to the lads. It just keeps me keeps me away from the drink. You need that in your head. You need peace of mind. It helps my personality to relax my whole body. My goal is to be working as a chef, to prepare food, doing pizzas and chopping up the veg and stuff.
I feel over the moon that I'm working. I feel that I am a productive member, that I'm not just sitting on the couch all day leaving the day pass me by. My head is not thinking 1,000 things a minute. When COVID first came along, I found it very difficult to deal with it. Before that, I kind of had my drinking under control, doing my classes, going on trips out and all that, so that was occupying my day for me. Then with all the lockdowns, all the restrictions, I felt like I was just stuck in the city with nothing to do. So there I turned to drink again to pass away the day, because the day is very long with nothing to do in it. Cork Simon community, I said, we promise you, the minute COVID slows down, you will be working. So I just took things slowly then. I've gone out riding my bike, staying away from the people that were drinking, long walks, anything just to pass the day. And in the back of my head was, I'm doing this not because I have to, it's because I want to. Do we see scheme? I do cleaning in the offices 2 days a week, 2 hours a day. And it gives me a purpose to get up on those 2 mornings, to get myself ready, get myself respectable, and head into work, as I call it, to go in to clean. It's not that hard to do, but it gives me a great pleasure doing it. But I do feel like I'm part of a team. Like, I feel like they're great support to me, and I just enjoy it so much that it's just unbelievable. They've seen how good I can be, how bad it can be, how hard I can work. They want you to come out of your addiction just so you can see a better future for yourself and what's out there in the world. They never stopped believing in me, and they said, look, you can do it if you put your mind to it, and I did. And I'm just standing out there looking forward to what the future holds for me.
I was talking to one of the lads always on about me going playing soccer, but it was something that I'd always say, yeah, probably next week. And when I got my new place, I kind of, no excuses now. So I said I'd go up. I enjoyed it totally. So I went again the next week and just want to continue. It feels brilliant, you know. I have the college course starting up in November, the first physical education course, nutrition and all that. I'm looking forward to getting stuck into it. Like, they're all doors that get opened from finally getting your own place. Like, they can send a letter out, something just as simple and basic as that, like, you know. Because my life wasn't like that for a very, very, very long time, like, and it's still not even where I would like it to be, but I'm definitely on the right way, you know what I mean? And I'd like to continue down that way and hopefully reap the rewards of living normal, positive, good life. Yeah, things are moving forward, so foot in the accelerator.
I think I won't wrap up for anything because I know I'm over time.
Thank you so much. And I hope you don't mind if we extend a little bit, a few more minutes. And I would like to invite Marta Borges. She is the Executive Director of Mainline. And we'll be addressing from the harm reduction perspective.
Sorry. Hi everyone, good morning still. I hope you're still, thank you for being still with us. That was super interesting, the video, so I was actually happy that you took a bit longer. Thank you for having me. My name is Meg. I work for Mainline. We are based in the Netherlands. And I was asked to talk a little bit about this whole concept of social determinants and integration of services in the concept of, or in the practice of harm reduction. So I'll be a bit quick because a lot has been said already. What we do with harm reduction, and we work in the Netherlands, but also abroad across the world, in particular outside of Europe. So we also work in a lot of low resource settings. So everything that I'm going to talk about in reality is not true. But this is sort of the idea of how we find harm reduction as a important approach. We use the definition that was defined by Harm Reduction International, a very broad definition of what harm reduction is, right? So attention for political situations, economics, and the social determinants that were all discussed this morning. I still like the definition. I think you're talking about changing it, but I still find it very useful. And we also draw a bit on the WHO that Jeff spoke about, of course, in the first section. Where we take a very broad definition of health. So this is not just the state of the body, but way more than just being or feeling well. This is about your mental state, but also your social situation. And social determinants really come back in this definition as well. So for us, harm reduction, of course, we work a lot in countries outside of Europe, and then HIV is of course always on the forefront. And then you have the comprehensive package that is harm reduction, and that we all find, of course, slightly limited because it's so focused on injection heroin use. So we are trying to also advocate in those spaces for a much broader uptake of harm reduction. So that is definitely also attention for basic needs. I really like the presentation about housing first, because I think it's one of the most important harm reduction interventions that are there. And I think that's definitely something that we need to fit better under the harm reduction frame. But of course, I mean, if you talk about people in the streets who are homeless, I mean, their basic needs are not being met. So that is something that you need to include in your harm reduction program wherever you can, I feel. So just access to a shower, clean water, food, stuff like that is definitely something that is often missing from programs. Attention for physical and mental well-being is something that we find also important, and health in a very broad sense. So, I mean, we all, or most of us, work with people who are homeless. Things like, you know, skin infections, you know, feet that are completely ruined from walking all day. Stuff like that is really important also to pay attention to, right? And that's definitely also something that pays attention to human dignity. If you talk about stuff like that, if you take care of people's wounds, if you take that very broad approach to their health and well-being. And psychosocial support and access to mental health care is definitely something that we always try to advocate for. Also in the Netherlands, mental health care is not always accessible for people. There's still an idea with doctors and therapists that you cannot access therapy when you're not sober. So there's always still a big struggle there. In countries where we work, in Asia, for example, we try to really build a community mental health response, where it's actually the field workers and the outreach workers that do a lot in terms of mental health. Also because there's an absence of therapists or psychologists around. And outreach workers actually can play a really important role there, and it doesn't have to be very expensive. So it's something that we're trying to integrate in all our programs. And then, of course, safety in a very broad definition. I find that drug testing, for example, drug consumption rooms really address a sense of safety. Housing First, of course, is another example of that. But also the attention for legal support and self-organization, human rights is something that we try to include in our sort of harm reduction approach. So this is a sort of a psychedelic picture that we did once for a proposal. It's a bit of an harm reduction wheel, let's say, and here what we try to do is sort of integrate all these different aspects. And you see their health, of course, as a very important element, but mental health is included, sexual and reproductive rights and health is included, safety is included, inclusion in society. So many of the social determinants that were talked about today are included there. And legal support, definitely very important. So I won't go into the details of this. I can share this slide. But what we find important is to make sure that we show with this that harm reduction is so much more than just passing out needles. That's just an entry point. And what we also try to really advocate for is to include people who are not injecting heroin users into this harm reduction approach. And with this, you know, sort of picture, at least it's quite easy to imagine what harm reduction for stimulant users, for example, can look like, because there's so much that you can do for people in that sense as well. I was really impressed by the presentation just now about the Women's Center. You know, there's a lot of groups, of course, that have sort of intersecting vulnerabilities, let's say. And I find it really important to pay attention to that as well. The proposal was rejected, by the way. I don't know why, because it's pretty smart. It's not our fault. We'll just resubmit. That was just very brief how we see harm reduction. I hope it connects a little bit also what you heard earlier this morning. And if you would like to talk more, come and find me. And now I hope that I talked so fast that the next speaker also still has a bit of space. So thank you very much.
And the next speaker is Catherine Schiffer from Correlation. She will speak about the Correlation Street Support Project.
No. You don't have a presentation, right? No, I don't. Okay. And I really promise to be really short. We're good. I don't even have a PowerPoint presentation. So, because that's a problem probably when you are the last one, that actually everyone has already said everything. So, I probably only wanted to address the point of what? Yeah, but it's in the middle of my face. Ah, very good.
Thank you so much.
So I wanted to address the problem of not the problem, the concept of social inclusion, and I think we didn't really address that yet. And what we saw, that if we talk about drug policies, it hasn't often been brought into context with social inclusion. And I think this is a good discussion which came up in the past years, and it's also very useful and important because it makes governments responsible for taking action to address inequalities. And it's also increasing awareness on inequalities and the impact of stigma and discrimination. What we see, however, also, and there are some critical remarks on the concept of social inclusion, because very often social inclusion is seen as something which brings people into the so-called society where economic productivity is actually the one and only thing what people need to be done. It's a kind of indicator if people somehow are in paid employment and are self-sufficient in this area, there are useful members of society. And I think this is a concerning development, and also something we should address when we talk about social inclusion and about integrated approaches. I also see that many of the social inclusion policies, if it comes to work integration, housing, also housing first is indeed a wonderful thing which is very much linked to harm reduction, that it's many interventions are mainly focusing on pulling people over the line towards society without really tackling causes of inequality. And I think this is something what we need to tackle as well. Also, that very often it's top-down policies which are not so much developed in combination with people with lived experience, people who use drugs, homeless people, all the groups we're talking about. And this brings people, funny enough, in exactly the position where we don't want to have them. So they are pushed again into a passive situation while we actually want to have people more active. And I think something which has been said already, we need more intersectional approaches. We need to be aware, and I mean, we are all, it's not people with complex needs, because we are all people with complex needs. I mean, we are not only a mother or a father or a worker or a person who's using drugs or is selling sex. We are different, we have different facets, and we have all different needs. So I think it's interesting that services reduce people to drug users or to sex workers only and do not address all the, and I think, the previous speakers have all addressed that already. So I don't want to go more into details. That just say, I think peer involvement and involving people from the community is important, and is probably one of the most essential things we need to address. And probably also, which hasn't been really addressed yet, monitoring and evaluation of services. And then I'm talking about not monitoring and evaluation from researchers, from the research field, but really promoting participatory research activities from service users to really see and not only look, for example, at access and availability of services, but also the quality of services. So that's it.
He is a harm reduction service provider for people who use drugs in Antwerp, Belgium. Please, Christoph.
Thank you.
I'm sorry for putting you in this hard
Yes.
spot. This is your presentation.
Yes. Hello, everybody. Already a lot of things are said, so I try not to repeat things. So I'm gonna skip some of the slides, and I also try to make it short and to just give you the highlights. The demographics are not that important for you, but I think what is really important is that we cooperate also between all service providers for drug care. So in Antwerp, we have a citywide cooperation project between 4 NGOs who work around drug care, and it's 3 outpatient services and 1 inpatient service. And in our support center, we work with a multidisciplinary team with psychologists, the sexologists, educators, the nurse, therapists, the social worker in family care, and things like that. I think it's really important because it guarantees different angles of perspective, and they are all taken in account to find the answers for the questions of our clients, because that's what it should be. That's what should be addressed: is answers to the questions of our clients. I don't gonna elaborate on all the figures, but I just want to highlight one. This one. We were able to prevent a criminal record for possession or personal use of illicit substances for 217 youngsters. So, and that's why we're happy for. So, but I think it's also very important from a harm reduction perspective is that you also should support people who live with people who use drugs. Because it's person-centered, and it's important. Of course, it's important that we listen to the client with the drug problem themselves, but also the people who live with that person who uses drugs, because they work 24/7 with that guy or women, and they really help. So you should use them, you should foster them, you should cherish them. Really, you should support them, because they make your therapy work. If we see regular counselors, they see a client 1 hour in a week, and those people who live with the user, they live 167 hours with them. So it's really important that you should support them, because they make the people who use drugs feeling that they are not in a tunnel. They feel that they are a meaningful part of society. And that's what recovery means. So get people connected, let everybody feel they are part of something bigger, and it's exactly the overwhelming added value of meaningful others that we never can deliver as a service provider. So please support them. Yes. It's also very important that we support other services who work with people. They should work with people who use drugs. So I think it's important that we support social frontline workers in adjacent sectors, because it's talked already a lot of in all these presentations. It's intersectionality. There is a lot of things that we have do together, and we all know that we can't save the world on our own. We can't do it for the climate, but we can't neither do it for social or psychological or health issues. So we need to work together. And we need those social services. And we need all the boots on the ground that we can have. And we cannot foresee all these boots on the ground, so we need the other things also around it. We need those boots on the ground to share the load and to multiply the results. So, and I think together we can create and we can co-create synergy. And it's already mentioned already a few times already. So we have to avoid the creation of parallel circuits, of the silos, things. We have to break this. And it should be normal for people who use drugs to use regular services. And it should be normal for regular services to include people who use drugs. So I think it's very important as harm reductionists that we also support people who work with people who use drugs. This one is already explained a lot of times. It's also a story about evidence-based things like that. Now, most harm reduction interventions are already so many times researched and already so many times proved as evidence-based. So don't be shy to shine with it. So use it also. Certainly in Belgium it's a situation that harm reduction in many occasions comes at the end of the line. If nothing else works, then you can do harm reduction. We don't think it's a good way of seeing it. I think it's important that you see what's the needs of the person, and if that's a harm reduction, then you need to deliver harm reduction. If it's a minor or not, it's not that important. If the question is, or is the answer is harm reduction, then harm reduction should be offered. Also, there is a lot of supportive evidence for that, and every step on the stairs of moderation, excess, or abstinence, it's movement, and if it's towards a positive direction, then it's good. Here we have to see also about generalistic and specialized approach. I think it should be intermingled. It should be both be concerned. So, that was the briefest last one.
I'm pretty